Hello, my name is Matt Robinson, and I'm the CEO of the Physician Association of California. Thank you for the time today and joining us for the 2025 New Laws Affecting Private Practice. For those of you that know, the Physician Association of California is a new trade association based here in Sacramento, advocating on behalf and solely on behalf of independent practitioners and small group practices throughout the state. We are excited to host this webinar alongside Hooper, Lundy, and Bookman to present to you some new laws that take effect in 2025 that were recently enacted in 2024. The great attorneys from Hooper, Lundy, and Bookman will discuss what the new law means and the application as it relates to private practice physicians. At this time, I'd like to pass it over to Robert Miller and Cole Hoyt with Hooper, Lundy, Bookman. Thank you.
Thanks so much, Matt. Robert Miller here. I'm a partner in the Los Angeles office of Hooper, Lundy, and Bookman, one of the co-chairs of the business department. I'll be presenting here alongside my colleague, Cole Hoyt, who's in our litigation department. So you've got two different perspectives here on these key developments that we're going to be talking about. Before we move into the agenda, just a couple of items about the logistics. Our contact information is posted here. For those of you who are attending live, thanks for joining us. Please feel free to drop any questions in the chat. Cole and I will take a look at those. We're going to spend about 45 minutes together talking through these key items. At the end of the presentation, we'll take a look at the questions. If we can answer them online, we will. If not, we will take them offline. So do include follow-up information if you would like us to respond. We'll also get you a copy of the presentation if you've registered. And as always, our contact information is available through the website. It's also on the very last slide that we'll present here. Feel free to reach out to us with any questions. We'd be happy to help. So here, as Matt mentioned, we're going to talk about these healthcare laws. This is specifically focused on independent physicians and small group practices. And these are new developments, always a popular topic. We promise you that we will leave you with some knowledge. You can impress your friends and colleagues about what's going on in California and what are items that you should be looking out for now that we're into 2025. I always like to set an agenda at the outset of the call. During this presentation, we're going to cover an overview of all of these laws, and I'll hit a few highlights for you on items that didn't quite make the cut for inclusion into the full presentation. And then in consultation with Matt and with PAC, we've broken down, we've got 6 laws that are now on the books that we're going to go to in depth. They're listed here for you in the agenda. And then my colleague Cole is going to talk a little bit about how those laws impact your practice. And then, as always, we'll talk about some trends that we're seeing, both in new laws and enforcement, and where we think the law is going, not just where it is now, but where we expect that it will go over this next year. So the list of laws, there's a lot going on in California. There's a lot going on in healthcare in California. I'm going to hit just a couple of these that we don't go to in depth. If they really resonate with you or your practice area, these are items that you would want to keep a close eye on. So a new law on the books expanding insurance coverage for IVF. So patients will now have access to those increased funds. IVF is going to get a little bit easier for Californians, a little bit easier to afford as well. Also, a long-running bill, an assembly member has doubled or put in place a bill to double the penalties for threatening healthcare workers. So it used to be that that was a 6-month offense. Now it's a 1-year offense. So giving a little bit more protection, raising the penalties on the idea that we as a society really need to be mindful of how we treat our healthcare workers. There are new implicit bias training requirements for all physicians, something to keep an eye on. So taking that implicit training requirement that already exists and then adding in a little bit more detail into what needs to go in to those training exercises. We have maternal health screenings. So this is expanding again an existing benefit where now maternal screenings include postpartum. So a decision from the legislature that they want to make sure that there's that focus on postpartum care for new mothers. Prescription labels for visually impaired. If someone identifies themselves as a visually impaired person, the pharmacy must provide a prescription label that's appropriate at no additional cost to that patient. Then psychiatric stays for violent offenders. You may have been familiar that roughly 5 days for a decision to be made under the old regime. Now that 5 days is expanded to 30 days. So the net effect is now there's longer stays for certain violent offenders under certain circumstances. AI, medical debt reporting, and licensure, we're going to get into in a little bit more detail. Alzheimer's, again, that's a training requirement. We're ensuring that patients who are giving care to a patient population affected by Alzheimer's have that experience and are aware and have some sense of training for dealing with patients who experience dementia and Alzheimer's. Again, happy to go into more detail on any of these items. If that sounds good to you, please drop in the chat. Please reach out to myself or to Cole, and we'll get back with you. But let's move on to some of these in-depth discussion items. The first one, and this is a big one, this impacts every independent practitioner in California. If you create medical debt with a patient, so for example, you provide a service, your patient enters into any kind of an agreement with you to pay for that service after the fact, you must include this language that's in the middle of the slide. So from January 1, so earlier this month, the legislature has added a requirement that says a holder of medical debt cannot furnish information to a consumer credit reporting agency without, at all. And that if the physician reports that medical debt to the consumer credit reporting agency, then the debt is void and unenforceable. Translating this into practice, all of your intake forms, any form you use with a patient or any suite of forms should include this contract provision here around medical debt. You should also train your staff, anyone who might be involved in your accounting function, to understand that you cannot make reports on medical debt to any consumer credit reporting agency. If you do, the practice cannot turn around and collect the debt from the patient. So again, this is a very important one that impacts the revenue cycle for practices. So want to make sure that we really emphasize this. Update your intake forms, train your staff so that they're aware of this requirement and they're not reporting that medical debt to consumer credit reporting agencies. Another big item here, one that's received a lot of attention in the press, is the raised minimum wage for healthcare employees. Now, this applies more broadly. It applies to healthcare employees across the continuum of care in a variety of settings, including facilities and including some physician groups. This law was signed into law back in October of 2023, but its implementation was delayed. It became effective close to the end of last year in October of 2024. And the covered employees, it's anyone that you would think of as providing patient care, certainly any clinicians, healthcare providers, physicians, nurses. For this context, when we talk about to whom does it apply, in the physician group setting, it applies to a group that includes a total of 25 or more physicians. So we flag that for you in the underlining there. What we've seen in other contexts is other regulators interpret a group of 25 or more physicians as including not just owners of the group, but also any employed physicians of the group, and also any contracted physicians of the group. So I want to raise that for you because you may be thinking, Well, I'm in a group of, let's say, there are only 10 owners, but we also have 5 employed physicians. So you may be thinking now I'm at 15, but consider whether you have call coverage agreements, whether you have specialists who contract with your group on an independent contractor basis. You really want to pay attention to the aggregation and how that might impact the application of this law to your practice. So again, if you think that you're close to that 25 physician threshold, or if you're not sure about the 25 physician threshold, that might be something to explore with your legal counsel. This law being so new, as of yesterday when Cole and I last checked, there was no regulatory guidance explaining that 25 total physicians. But again, we did want to share with you, we're familiar from other contexts that regulators will take the position that includes, again, not just owners, but employed physicians and contracted physicians. For those of you that have staff who are on a salary basis, we've included here the formula that the law uses to hit that hourly wage. And so if you take the salary and divide it by 2,088, you get an hourly rate. What you would find is for that first tranche of that minimum wage at $21 an hour, that again, that goes into it, or that is in effect for physician groups with 25 or more physicians until May 31st of 2026. That's roughly an annual salary of $44,000, just a little under $44,000. So something to keep in mind. And then of course, that goes up in 2026, and then it goes up again in 2028. Our next topic that I wanted to talk to you about is artificial intelligence. This is red hot across all varieties of provider groups across the continuum of care. There is a lot of interest, a lot of excitement over how AI is going to impact care delivery and improve patient outcomes. One thing that we have seen is that AI regulation, that is the laws that the legislature passes, the regulations that enforcement agencies put out, tends to lag a little bit behind usage. And so I think what you would see here under AB 3030 is the legislature reacting to something that a lot of us have probably experienced in practice. Here, this law is concerned with the use of AI in healthcare communications. The classic example would be a chatbot on a website for a physician group. So if your physician group or your office uses a chatbot to talk to patients about healthcare delivery and including patient clinical information, then you must include a disclaimer if that communication is generated by AI. Now, there's an exception here for where a human reviews that communication. So it really is that facts and circumstances dependent test where you want to consider, is this a communication that I want to run by a provider? So is it AI is going to generate it, send a draft, and then the draft is reviewed and published? In that case, you don't need the disclaimer. Or is this an instant feedback scenario where a patient uses the chatbot or the tool, and then it instantly generates a response? In that case, you do need the disclaimer. You also need to include, if you do use AI tools, how a patient can contact a human. And so again, if you don't have the disclaimer because it's reviewed by a human and the patient could contact a human by responding to that chat, that might satisfy that requirement. But again, be mindful of how you're integrating these AI tools into your practice and how you might need to consider those workflows that you have in place now. A similar AI bill here. So we have the Physicians Make Decisions Act. This one is more focused on the health plan side, but it's very relevant in a managed care context organization. So again, this took effect at the beginning of the year. What this bill is designed to do is regulate how AI is used in utilization management and utilization review decisions. A former colleague of mine used to say, AI is all about don't let the robots practice medicine. And I think that that's a really helpful principle here. And so when you're thinking about how am I using AI in practice, AI cannot substitute for the decision making of a physician, cannot replace the physician, cannot replace healthcare decision makers' authority to approve or deny or make care decisions. And this bill's really getting at that again in that managed care health plan context. And particularly, it wants to make sure that any of those determinations around care decisions are made with human oversight. So we're seeing a theme here with AI. Don't let the robots practice medicine. And two, if you're going to use AI, make sure that there's adequate human oversight, that you have a healthcare provider acting within the scope of her or his practice who's reviewing those decisions. This law also goes a little bit beyond that. It talks about the AI must factor in that enrollee's medical history, individual clinical circumstances, and other relevant medical records. And so that displays a concern about AI being trained on either just publicly available data or trained on a subset of the population and not taking into account those individual circumstances. Then we also have a requirement that anyone using AI tools in this context, so plans and insurance companies, they have to explain how those AI tools are used in utilization review, and then they have to be applied fairly and equitably. And so one of the longstanding concerns in use of AI and its integration into healthcare is ensuring that the data set is robust enough to take into account differences in healthcare outcomes among different patient populations. And so just as that concern has been expressed in care delivery concepts, here the legislature is telling us they want to make sure that that's also happening on the health plan side of the ledger. Unlike the prior AI bill, where you're really thinking of the medical board who's enforcing the disclaimers around physician practice use of AI, here, because we're talking about that managed care context, this is DMHC, or the California Department of Managed Healthcare, who would be most concerned with enforcing the statute and who's charged with creating regulations and otherwise seeing that it's carried out. I'm going to turn the slides over now to my colleague, Cole, who's going to talk to you about a couple of other laws that we want to get into some in-depth discussion around. And then we're also going to transition into that more forecasting phase of the presentation. We'll talk to you about how we think this is likely to impact yours and similarly situated practices. And then again, finish with where we think the law is going to go, and happy to entertain questions at that time. Thanks so much.
Thanks, Rob. As an introduction, my name is Cole Hoyt, and I'm an associate here at Hooper Lundy & Bookman in the Los Angeles office. Before I get into some of the slides, I wanted to explain why this presentation is important to me. My wife is a physician, and her mom and dad are both physicians, and her brother is a physician, all practicing in Southern California, all in private practice. And for the past 13 years, I've had this really unique experience of seeing what life is truly like for a provider in California, particularly doing private practice. And what I've seen during this time is the increase of private equity, the increase of health plan profits, the increase in medical school education costs, in the increase of regulation and other administrative burdens. But at the same time, we've also seen a decrease in patient satisfaction, a decrease in the amount of time a provider has to put hands on patient, and a decrease in the reimbursement rates from Medicare, Medi-Cal, and other commercial plans. And all this is to say that we truly understand the pressures that providers in California are facing, but there are a lot of people in your corner who are here to help. Our law firm HLB certainly in that corner, PAC is no doubt in the corner, and there's a lot of people on your side. And so we encourage practitioners to reach out for help when needed. So now moving on to AB 2164, which is the physician license renewal. So this is a new law that came into effect that prohibits the Medical Board of California from requiring an applicant for licensure to disclose a condition or disorder that does not impair the applicant's ability to safely practice medicine, and also prohibits a condition for which the applicant is receiving treatment but does not impact the applicant's ability to practice medicine safely. The one caveat is that it allows the medical board to require disclosure and participation in a treatment program if that resulted from an accusation or disciplinary action brought by the board. You'll see this next time you go to renew your license. In reading into the law, we believe that the legislature is trying to strike a balance between protecting physicians while at the same time protecting patient safety. Now moving on to our next topic, AB 2258, which is preventative services. As a background, California really has been leading the nation in preventative measures and making health plans essentially take on that cost. We saw that a few years ago with SB 510, which in essence mandated health plans to cover the cost associated with some COVID-19 responses, such as laboratory testing and vaccinations, as well as other E&M. And we now see the state wanting to provide preventative services to Californians. And so in essence, this law prohibits a health plan from imposing cost-sharing requirements for services of preventative care service and screenings. And it highlights what those preventative services and screenings are by referencing certain organizations and entities within the bill. So for example, evidence-based items or services that have an A or B rating per the United States Preventative Task Force. You could go on to the United States Preventative Task Force website, and they have a chart that is kind of by practice area that details their quote A and B recommendations. But some of these services include BRCA, breast and cervical cancer screenings for Alzheimer's. Next, there's also coverage for immunizations, and those immunizations are based on the Federal Center for Disease Control and Prevention Advisory Committee practice group. And finally, infants, children, adolescents, and women are also mainly covered under this preventative care services and screenings statute. And for those, you could look into the United States Health Resources and Services Administration. Now, we'll caveat this by saying what's interesting about this bill is that there are references to federal health programs which, quote, cover the preventative care services. And with the new administration, it remains to be seen how that and how those practice committees might change what is or is not covered. And Rob and I anticipate should there be changes, for example, based on the United States Preventative Task Force recommendations or the immunizations covered by the advisory committee, that the state might amend or create new law to continue coverage of Californians. Next, we thought it'd be helpful, now that you've heard kind of these key highlights of laws, what considerations should you take into mind when learning or researching these new laws further? So first and foremost, you need to understand when the law takes effect. Most often, as we've seen here, the law will take effect in January 1st of the year, but it's important to read the fine print. As we've seen, sometimes they're delayed, and it's important to know when it starts. Relatedly, it's critical to see how the law might change over time. We saw here today with the minimum wage law for healthcare providers, there's kind of a ramp up period. So over the next 4 or 5 years, the amount per hour changes. Next, it's important to see whether there's exemptions. We've also seen in that law that the practice size matters. 25 physicians or more is different than if you're a solo practitioner. As we mentioned, there is kind of this rift right now between state and federal, and it's important to see whether the state law references federal law, or conversely, how federal law might impact a state law. What I like to do is to see where the law lives. And what I mean by that is where in the actual section, the code section, does the law kind of become implemented, and that provides additional helpful context. Next, what's really important is to see who is enforcing the law. And that's critical because are you going to be dealing with the Department of Healthcare Services or the Department of Managed Healthcare or the Medical Board of California? And so really taking into account kind of these basic characteristics will help, or hopefully help, all practitioners get a better grasp of here's a new law in California, but what does that mean and how do you go about analyzing how that law affects you? Next, it's important to see how these laws impact your practice. Considerations that we recommend to practitioners is whether or not one might have to take proactive measures to comply. Towards the end of the calendar year, usually we'll get the final list of what laws will be implemented the following year. And oftentimes that doesn't provide a lot of time for providers to get into compliance. And so it's important to stay up to date, and we'll get to this in a second, but seeing how the laws might impact you and what proactive measures you might take. If you're not in compliance, but you think you should be, we always recommend talking to a lawyer, either here at HLB or others that practice in the healthcare field. Even if you are not in compliance, there's ways to help get you into compliance. Next, the question that we often always get to is how could one stay up to date? As Rob mentioned at the outset, there's dozens and dozens of new healthcare laws in California, and that doesn't even touch about federal healthcare laws. And so we recommend reaching out to either law firms or trade organizations. Oftentimes law firms will put out bulletins, and same with trade organizations such as PAC. We recommend reaching out to PAC and other trade organizations based on your practice group. Connecting with peers is also a very helpful way, particularly in subspecialty areas. Reaching out to those in your fields and just getting to know one another and talk about what laws are coming up and how other groups are navigating is also helpful. Finally, what we recommend is try to be a part of the legislative process. Those who speak up often get heard, particularly when it's coming from a practitioner's point of view. And there's numerous groups such as PAC who make it a point to be a strong voice for practitioners. And so, get involved with trade or lobbying organizations, engage with your elected representatives, and make your voices heard. From our experience, some of the most impactful voices in our legislative process are directly from physicians. A lot of people in society, most will kind of defer to physicians or hopefully defer to physicians. And it's really important to make your voices heard. So finally, we wanted to wrap up with kind of these hot topics that Rob and I have been seeing in our practice over the past few years and what we anticipate will continue to be in the news and be highlighted in the next few years. As you've seen today in the presentation, artificial intelligence is kind of at the top of that list. AI is kind of taking over all aspects of our society, and healthcare is no doubt a major part of that. And particularly being in California, which is often kind of seen as a leader in technology in the United States, we have seen laws relating to artificial intelligence, and we no doubt expect to see many more in the short future. Private equity has also been a hot topic, and we continue to believe that that will remain a hot topic for a number of years to come. We've seen health equity and providing quality patient care to all Californians be in the news and find its way through state laws, and we think that will also continue. After the overturn of Roe v. Wade, reproductive rights has seen a lot of attention. And again, with this new administration, we anticipate more focus on reproductive rights. Next, combating federal law and policy. California has oftentimes taken the position, sometimes that is not in line with federal law, and tries to kind of combat federal law. We see that particularly in reproductive rights, but there's other areas as well. And finally, healthcare coverage and affordability, particularly since COVID, as costs have increased, there have been a strong focus on providing, again, affordable healthcare to all Californians. So that concludes our presentation. I'm gonna go and check and see. Right now, there's no questions or answers, but should you have any questions, please feel free to send us an email or to reach out to PAC. Thank you.
Thanks so much, Cole. I'm going to jump in quickly here. We did have one question come in, but also just expanding on what Cole had said. One thing that we didn't do in the presentation is go into too much detail about what laws didn't pass. And I'll tell you that in part, we want to avoid confusion by putting those in the same presentation. But we've got a few minutes here, and we only have the one question that I'll answer in just a moment. So I wanted to call attention to AB 3129. And I suspect many of you are familiar with this bill that ultimately did not pass, but would add another layer of review of any transaction involving certain physician groups and private equity groups or hedge funds. And especially in the context of Cole's talk about national trends, that's part of a national trend toward the legislature becoming much more interested in not just healthcare practitioners and how they practice medicine, but also who is it on the business side of those healthcare operations. Oregon, for example, just north of us, already has a law on the books that does include an additional layer of transactional review by regulators. Massachusetts, in the wake of the Steward Healthcare bankruptcy, which I imagine many of you were aware of, also contemplated another law, and there were efforts in other states across the country to put in place similar, again, regulatory regimes where there would be a pre-transaction review of that deal. When I say that, what I mean is that an individual physician or a physician practice, that there would be regulatory review if you, for example, were selling your practice to a private equity-backed or a hedge fund-backed group. And as we've seen when we're talking about these bills on an individual basis, the definitions matter. So just like the term physician group might be defined as 25 or more physicians, and then you have to consider the aggregation rules, who is or what is a hedge fund or a private equity group could become a really important consideration. One question that we did receive from the audience was going back to the medical debt piece. I do want to emphasize again, and I'm going to take us back to the slides, so bear with me as we flip through for a moment. Okay, SB 1061. So we are aware, and our questioner asked, there's been some information suggesting that medical debt is no longer collectible. And that is not true. It is not true that medical debt is no longer collectible. Again, I want to emphasize, medical debt can still be collected. The wrinkle is it can be collected so long as you meet the administrative requirements of this new law. And that gets us back to what we had touched on before, which is including this contract language. So any contract creating medical debt entered on or after July 1 must include these specific terms. There are a few instances under California law where you have what I like to think of as magic words. One of them comes in the context of a release. This is another, a new instance of where we now have magic words from the legislature. So the practical takeaway is you should copy this sentence. A holder of this medical debt contract is prohibited by section 1785.27 of the Civil Code from furnishing any information related to this debt to a consumer credit reporting agency. In addition to any other penalties allowed by law, if a person knowingly violates that section by furnishing information regarding this debt to a consumer credit reporting agency, the debt shall be void and unenforceable. That sentence should be copied and pasted into your intake forms, into any contract you have with a patient by which it could create medical debt. So think about the document by which the patient agrees to pay you for the services that you have rendered. That second sub-bullet point there says, if that term isn't in the contract, then the debt is void and unenforceable. So a medical debt is only not collectible. You don't get paid only if, one, you fail to include this contractual provision in the agreements with the patients, or you knowingly violate this code section by furnishing information about the debt to a consumer credit reporting agency. The guiding principle behind this, and the thing to keep in mind, is that very top bullet point, where the legislature is concerned that medical debt does not necessarily reflect on the credit worthiness of an individual. And the way that the legislature has gone about excluding medical debt from credit reports is by placing the onus on a provider group to educate its staff and to tell its patients that that provider group will not report on that debt to a credit reporting agency. Now, again, definitions here are important. Credit reporting agency means exactly who you think it might mean, right? Anyone who reports to any of the large credit reporting agencies, anyone who might put that debt into a system that gets reported to those credit monitoring or credit reporting agencies. For all of you that use an outside vendor for your rev cycle management or your revenue cycle management, this is something that you might want to ask them about, especially if you use a national vendor who may be out of state, maybe they're not familiar with this law. But again, this is an area where it's adding that slight additional administrative and regulatory burden. But our view is the best practice is to pull that language into those intake forms, talk to your staff about this, make sure that your vendors are aware of it, and implement these changes so that you don't run into issues when you're trying to collect from patients on those medical debts for services rendered. That is the only question that we have received live here. I'm happy to entertain any other questions. We wanted to reserve just a few minutes at the end. So we will hang on for another few moments. Let me jump back to the slide at the end here that has our contact information. And I'll leave that up for the group. And in the meantime, please do tell us if there's anything else that we can do to help. Cole and I are passionate about helping providers comply with the law. There is always a lot going on. There's going to be more going on this year. Matt and the team at PAC are a great resource for staying on top of these developments. We've really enjoyed working with them and putting together this presentation. And we're very happy to have met this group, and we'd welcome any future questions. Otherwise, I think we will wrap it up here. Okay, thank you all very much for joining us today on your lunch hour. We hope you're able to walk away with some new information, and we look forward to hearing from you in the future. Thanks so much.